Thank you very much, Chairpersons. We come to the last session of the day, and this session is concentrating on high tibial osteotomy. And my take today is to speak to you on HTO, the proper indications and preoperative planning. So all of us know that the role of osteotomy is proven. It of course unloads the affected medial compartment, which tends to carry more load as you age. HTO, it also realigns the weight-bearing axis to the lateral side, and it also increases the blood supply, thereby causing a decongestion effect and reducing the pain. So this is known to us. We have seen the long-term results from Cecil Rorabeck from Canada, who has shown us that a well-performed HTO can last up to 95% of the cases 5 years, 85% to 10 years, and 75% to 15 years. So Cecil Rorabeck has given us the classical indications for doing high tibial osteotomy. And if you see, this is also going to reflect in the debate that the case scenario, the indications for an high tibial osteotomy as compared to a unicondylar are quite similar. I would say an ideal HTO patient would be a younger one who has a more active lifestyle, wants to continue sporting activities, a varus deformity of 15 up to 15 or less than that, a flexion deformity of less than 15, not more, well-localized medial joint pain. If the patient has a good ROM of 120 or more, there should not be any ligament instability like ACL, PCL or the other ones. And definitely the patient has to have an intact lateral compartment, even though the extended indications can be done, but an ideal patient for an HTO has to fulfill this criteria and BMI preferably less than 30. So these were the indications which are known to us, and these quite closely mimic the unicondylar knee replacements. In which conditions would you not definitely do HTO, tricompartmental OA? More so with ligamentous instability, a lateral varus thrust, which has been proven even to give bad results, though you can modify your osteotomy and deal with that. But I think for a classical indication, that would be a no. Obesity, these are the patients you would not think of doing high tibial osteotomy, or for that matter, even a uni, and probably total knee replacement would be the way to go. There are various factors which influence the results of a high tibial osteotomy, and the most important thing is to get an adequate correction, probably an overcorrection into valgus, and I will show you in a couple of minutes how one can get that. End of the day, it is important to get the proper alignment first and to maintain it. Over a period of time, we have seen that we do get the correction on day one, but as time goes, we lose the correction and the patient starts getting pain and your HTO might fail. Why is it so important to get the proper correction and maintain it? Because there will be a recurrence of deformity, otherwise the pain will come back and the patient will be unhappy. And there are various ways how we can find out how to really overcorrect or get that valgus. So this brings up to the point of preoperative planning, which is the main crux of my talk today, and I think it's important for us to plan well. First of all, you've got to ensure that the deformity is from the tibia and not coming from the femur or from the joint line, or it's because of bone loss. Because if it's any of these other than the tibia, then probably you've got to address the problem in a different way. For this, it's important to take the proper history. You've got to clinically see for stability, see the range of movement, assess the deformity. X-rays are the most critical thing. MRI can be done in certain cases because it gives you a lot of good information. Full-length X-rays are mandatory according to me, and you should develop this at your center. Try and get the digital software for this, and it's not very difficult to do it. A good X-ray, a lateral X-ray in full extension or whatever maximum possible extension is important, so that you know you're not dealing with any deformities, a tangential view of the patella, and a single joint weight bearing view. So these are the various views which you should always do. Now it is very important to take, can you hear a full length scanogram very well, and there is a way which has been described to take it. It should be a 51-inch cassette, the minimum distance of 10 feet, and the patient has to be standing. Another important thing, please note while taking this, is that sometimes your patella is facing outwards. You've got to make sure that your patella is facing in front, and this is a very important thing, otherwise your calculations will go wrong. And this is how your patella has to look in front, and for that time you might have to internally rotate your foot and the limb so as to get the patella in the front. At the same time, if there's a pelvic tilt, you might have to put some raising blocks below and then correct it, the pelvic tilt. So these two things, unless you have them, your scanogram is not going to be proper, and you're going to get wrong information. Sometimes if there is severe varus or severe valgus, it does not fit into one X-ray, and then you've got to move on. That to the radiographer adjusts in a different way. And MRI is important, and MRI will definitely tell you whether there is any extrusion of the meniscus, if there is edema, and if there are mechanical symptoms, then you might have to scope the patient before doing an HTO. Otherwise, most of the times you can go ahead with the HTO without scoping it. Now, coming to the calculation part, this is the mechanical axis deviation test that's also called as the Mikulicz line. That is a line passing from the center of the hip to the center of the ankle, usually passes in the center of the knee, plus minus 2 millimeters on either side. So this is a Dror-Pele's work where you can find out whether you're dealing with a deformity which is in the femur or the tibia, or whether the deformity is in the joint. And for this, you've got to first draw the Mikulicz line, or also the mechanical axis deviation line, that is a line joining from the center of the hip to the center of the ankle. You can draw this line at the same time, you can draw different angles. So if you see that this line is passing on the medial side, then it's a varus deformity. If it's on the outer side, it's a valgus deformity. There are three main angles which you have to calculate. This is the mechanical axis of the femur, this is the mechanical axis of the tibia, and there are three angles which are important. One is the mechanical lateral distal femoral angle, that is the LDFA. Then is the medial proximal tibial angle, which is again the MPTA. These two are very important. And third is the joint line convergence angle. So if you get these three angles right, then you can know whether the deformity is in the femur, the tibia, or is it in the joint line. So that is something which is very critical. And this brings us to what I've just told you, the mechanical axis deviation test. You draw the three angles, you draw the lines, see where it is passing, and then you know whether you're dealing with a valgus or varus. So this is very important. Full leg X-ray, line from the center up to the center of knee, see where it passes. If it is going outwards, you're having a varus. If it's going medially, it's a varus. If it's going laterally, you're dealing with a valgus. So that's how you come to know. And we are talking here about the medial compartment OA. So it has to be a varus deformity. Then you draw the three angles which are there. First is the lateral distal femoral angle, which is usually 85 to 90. And if it is less than 85, then there's a valgus deformity in the femur. If it is greater than 90, then it's a varus deformity in the femur. The next angle, which is very important, is the MPTA, medial proximal tibial angle. Less than 85, varus deformity, and this is what you're going to see most of the times when you're trying for when doing a HTO in this varus deformities. Greater than 90, then it's going to be a valgus deformity originating from the tibia. So this is very easy. As long as you get a good a long leg X-ray, a good scanogram, these calculations are not at all difficult for you. Then third is you draw the two joint lines, the lower femur, the upper tibia, and then you see the convergence. So depending on where they converge, either medially or laterally, then you're dealing with a joint line deformity because of ligament laxity leading to varus or valgus. So these are the cases again which are not going to be very suitable for your HTO. There are two more points which I would like to tell you about. That is the Fujisawa point. This is a point which when you overcorrect, your new mechanical axis should pass through. You divide the lateral compartment from 0 to 100, and this point is between 30 to 40% of the lateral condyle of your tibia. So this is where your new axis should always pass. So please remember that. And if you see on the X-ray, then this will be the line which is at the base of the lateral tibial spine. So just about a couple of millimeters lateral to the base of the lateral tibial spine is where your Fujisawa point is, and that's where your line is going to pass. Next is the Miniasi technique. They have a Miniasi point, and this point is a little more further than what has been described by which we saw. And this point is a little more lateral, and I'm just going to show you that this is the mechanical axis. You can see the line from the center of the hip to the center of the ankle is going varus. So this is where the point is, and this is about 50 to 70% away from the center of the tibia, and this is the Fujisawa point is about 30 to 40, and this is even further. Just take a couple of minutes more. So, and this is how you draw the axis. So this is very critical, and then you can decide whether you want your point at the Fujisawa point or you want the point which is at the Miniasi point. Another critical thing is you've got to decide whether you're doing an open wedge or a closed wedge, and where is going to be the apex of your correction. So if you're doing a open wedge, then it's at the proximal part of your fibula, just at the tip of the fibula head. And if you're doing a closed wedge, then another line joining straight about 1 centimeter below the joint line, 8 millimeters to 10 millimeters. So this is what you have to plan before, because this is again an important slide. You take the long leg x-rays, you first draw the mechanical axis, see where the limb is passing through. Then you plan where you want it to go, whether you choose the Fujisawa point or the Miniasi point. And then you draw another line which is going to pass through that. Then you decide the apex if you're doing an open wedge, where you're going to get the point, and then you connect this to the center of your ankle, where the mechanical axis is here. So this angle which you get is the angle which is called as alpha, and then you get this angle, and that angle will transfer to the height of your osteotomy. So this is very well described in the Clinical Orthopedic Journal in 1989, and you should follow this, and it's not very difficult to plan. Once you get the H angle, the height, that can be again extrapolated to your wedge, and I'll show you in a minute how this H, the height of the osteotomy, can be extrapolated to the amount of correction you've got to get. Similar thing which can be done for a closed wedge. Again, you get the point where the osteotomy is going to be. You plan the mechanical axis which is going this way. Then this is your angle which has to be corrected, and then you can find out what is the wedge which you require to close, and then this is the way you can do a closed wedge osteotomy. So you decide. Most of the times we are now doing an open wedge osteotomy. Whenever you're converting that angle to your height, if it is, let's say, angle is 12 degrees, then you're going to get a wedge of 12 millimeters you've got to open. But this is true only if your tibia is 56 millimeters to 59 millimeters wide. Otherwise, then you've got to apply this formula. And this has been described very well by Hirungu, where he gives us a complete chart on how many, if it is 9 degrees and your length of your tibia is 60 millimeters, then actually you will be 9. But if it is 70 millimeters, then your angle which you have to take is going to be, the height is going to be 11. So this is something which you have to plan well, and you can exactly calculate the amount of wedge you have to open. Again, it is important to overcorrect. It is important to not lose the correction, and you should always pass on the lateral side either 40% or 60%. There are various softwares which are available, and this particular software has been available with the AO group, and this has been described in the KSSTA, where you can actually extrapolate and calculate digitally what is the correction required. So friends, I think selecting the right patient is very critical. You've got to plan pre-operatively what is your height, the wedge you're going to open, and always have an overcorrection. So HKA of 4 to 6 degrees, or if you follow the femorotibial axis, then it has to be 10 degrees or more. And for me, an open wedge osteotomy works better than a closed wedge. And definitely this is a procedure of choice in the young active patients. Thank you very much for your attention.